These are our grand rounds that happen the third Tuesday of each month. We will be recording this, and with Dr. Ryan's permission, we will also be sharing. So today she is here to talk about using steroids in the NICU for BPD, and has a great opening slide. She is a professor of pediatrics at Case Western, and a senior attending neonatologist over at Rainbow Babies, and a senior author for a very pertinent review that we will put in the chat. She's also been a chief of a division, a chair of a department. So all questions I think she would welcome. Thank you so much, Rita, for joining us. And the stage is yours.
Thank you. And thank you, Clara, for inviting me. And for those of you who don't know her, whenever you're invited by Clara, it's always going to be an event of some kind, you know. So I'm going to be talking about steroids, and I have to give credit to the person who developed this title. Hanz and Franz want to pump you up, using steroids in the NICU for BPD prevention and management. The credit goes to a nurse practitioner named Carmen Dooley in Charleston, South Carolina. And I've just she used it for one of the talks I gave there, and I've just kind of kept the title because other than, you know, it's kind of fun. And of course it does date us a little bit. For those of you who don't know who Hanz and Franz are, here they are, Dana Carvey and Kevin Nealon. And I guess this skit from Saturday Night Live was based on them watching a interview in a hotel room with Arnold Schwarzenegger. And some of you may remember that he actually came on the show and did this skit with him. So it's just kind of a fun thing. So why are we talking about steroids? Well, BPD is common. We know there's an associated increased risk for poor neurodevelopmental outcomes. So that makes it even more important. Inflammation is a part of the pathophysiology. Corticosteroids have anti-inflammatory properties. So that's why people think they might be useful for BPD. And the ones we're going to talk the most about are dexamethasone and hydrocortisone. That's the ones that we have the most data about. And a little bit about methylprednisolone or prednisolone, that we don't have quite as much data for those. So for those of you who really like to understand the mechanism of how steroids work, I direct you to this beautiful review. It's a little bit old, but it was very well written in 2005 in the New England Journal. And what happens is cortisol binds to its receptor, and then this receptor cortisol complex is what does all the affecting of everything. It can go into the nucleus and function as a transcription factor. It can go in the nucleus and bind with other transcription factors. And it also can have effects out in the cytoplasm directly on protein. So I'm not going to go into any more detail than that. But for those who really like this kind of stuff, I've given you an article. So we are using a lot of postnatal steroids in our world. We use hydrocortisone and dexamethasone as prevention and early treatment strategies for BPD. We have pretty good evidence now that it is effective in reducing BPD. It's effective in decreasing respiratory support, and it's effective in facilitating extubation. There's been a notion that hydrocortisone may have a little bit lower risk for neurodevelopmental impairment compared with Dex, and I'll kind of get into this a little bit more later, maybe not, and we'll talk about that in a little bit. It's been long known for some time now, the Cochrane reviews have sort of changed, that anytime studies were done and the babies started when they were over 7 days of age, there was not an increase in neurodevelopmental impairment. That's changed over time, but for a long time now, we've known that. And even some of the Cochrane review, the more recent Cochrane reviews have said that about starting less than 7 days, but we'll talk about that. There are no head-to-head randomized controlled trials of Dex versus hydrocortisone that I'm aware of. And then I'm going to talk a little bit at the end about prednisolone for established BPD. And we'll be working with our PEDS POEM colleagues at that point usually, and there are no randomized controlled trials for that, even though everybody seems to like doing it. So this is data from something called the PROP study, which stands for Prematurity and Respiratory Outcomes Program, and I was lucky enough to be part of this program. This is based on babies enrolled in these years who were less than 29 weeks. And if we look at, this is a paper on all the medication data that we collected. And if you look at the steroid data, it's mostly Dex and hydrocortisone. If you look at the whole cohort over here, roughly about a third of the babies will have some exposure to any systemic corticosteroid. This is at any time during the hospital course. Of course, this is a lot higher in the very immature babies. As they get more and more mature, that goes down. And remember, this is at a time when we weren't using as much steroids. So you can see that it's still a healthy amount of babies who are getting this exposure. And I love this graph, so I had to put this in here. This is looking at the peak of these humps, for lack of a better word, tell you the percentage of babies in the NICU who were exposed to the drug. And the shoulders of the hump is the median start time and median end time. This is by postmenstrual age, and this is by chronologic age. And you can see that there's a lot of other drugs that we're using that we don't have a lot of data on. We actually have a lot more data on hydrocortisone and dexamethasone. So it just kind of gives you a feel for how much we're using and when we're likely to use it. Now, this has a bit of a pendulum kind of thing going on in neonatology. You know, the idea that steroids are good. Inflammation is important for the pathophysiology of BPD, and steroids are anti-inflammatory. And BPD itself is associated with worse brain outcomes. So maybe this is a good idea to try to make less BPD. But on the flip side, steroids are bad. They can be associated with intestinal perforation. It's bad for the brain. And in 2002, some of you will remember in real time that the AAP and the Canadian Pediatrics Society told us do not use, and it was like a big deal. What do you mean do not use? And so it turns out it's a lot more nuanced than this. It's not so straightforward. And there's things about dosing and the type of steroids and timing of when the brain is exposed and the optimal population. And there's crossover in some of the studies. And, you know, do we really have great surrogate outcomes for both the lung and the brain? So there's a lot to talk about. And this group of authors here did write an article. Now it's getting to be almost 10 years ago, Stopping the Swinging Pendulum of Postnatal Corticosteroid Use. And I really like this paper. It kind of frames the question. It kind of gives a lot of good references. It points out the trials that are coming and the trials that were stopped early due to loss of equipoise. People freaked out when the AAP made that statement. Nobody would enroll kids in studies anymore. And so we kind of lost an opportunity to really gain more data. So I'm not going to talk about this anymore, but if you like this kind of part of the subject, this is a good thing to put in your armamentarium to read. Now I am going to talk about it, and I think Clara actually is going to put this paper in the chat, but it's an article that we wrote a few years ago now, and good number of the people are from Rainbow. There are two of these guys are both pharmacists. Lucy Mastrandrea is a pediatric endocrinologist from Buffalo who helped quite a bit. Alan Jobe is Alan Jobe, and I can die happy now because I published a paper with Alan Jobe. And I'm going to lean on this article quite a bit, as you will find out. So those of you who read it, you're going to have seen some of this before. So we kind of divided the time periods up a little bit just for ease of decreasing confusion, because I don't know about you guys, but there is a ton of these studies to think about. So the first time point is if you're going to start before day 7, we consider this prophylaxis. Anything after that, we really feel like you can kind of guess which way the kid is going, toward BPD, not toward BPD. So prophylaxis means you're going to give it to all of the babies. So that means that for this Premilox study, you know, they treated everybody. So that means some babies who would never have gotten BPD are going to get this steroid exposure. And I think this is an individual choice for your unit or for your personal practice. And we kind of put this in here when to use. Maybe consider if your unit rate, if you know your own unit rate is high. How do we define high? Well, you could compare yourself and look at the 50th or 75th percentile in Vaughan or some other benchmark that you want to use. And consider this if you know you're particularly high, this might be a strategy that you could use. In this study, they gave it to babies who were 24 to 27 and 6/7 weeks gestation. There are some cautions with this practice, and that is you can't use it with NSAIDs due to the risk of intestinal perforation. Neurodevelopmental impairment actually improved in the lower gestational age cohort, shockingly. The neurodevelopmental outcome actually just came out a few years ago. And then they took about the first 90 kids in this paper, that's from my memory, so don't quote me, and they did ACTH studies on the first 90, and there was never any adrenal suppression, so they stopped doing the ACTH studies on the rest of them. But so there's your references, 2016 and 2019 for this particular cohort, this particular studies. Now, if we move on to, we kind of put a break in at 28 days just to kind of keep ourselves organized. And we call this early evolving BPD, for lack of a better terminology. And of course, the famous DART study and the other study that's dexamethasone, and then Stop BPD, which is hydrocortisone. And these two studies, kind of are tackling the same time period. They're not prophylactic. Kids had to meet certain criteria. For both of them, or rather, one of them is 28 days and 28 weeks, and one is 30 weeks, and I can never remember which one is which. And they're babies who are still on a ventilator after 7 days of age. So we know that babies who are in that cohort of being on a ventilator between day 7 and day 14 have a very increased risk of BPD compared to the kids who are not on a ventilator. And that's on a ventilator for any reason. Apnea, prematurity, their lungs look bad, their lungs don't look bad. Just being on a vent alone is a serious increased risk factor. And so that's what a lot of these studies use to decide, am I going to give the kids steroids or not? So I think for me, I think you can consider giving DART at around 3 weeks of age. If somebody really wants to give a steroid earlier than day 21, I usually don't. But every once in a while, somebody really feels like this kid's lungs are really bad and, I want to help, and what can I do? I think you could make an argument for maybe trying hydrocortisone instead. And both of these studies were efficacious. So, just something to consider. And I'll talk a little bit more about the brain stuff later. But just to let you know, DART was started at a mean of 23 days. There was no upper limit reported in the paper. And the Stop BPD protocol, that study, were only for babies who had to get enrolled in the study between 7 and 14 days. And once they were past 14 days, they were not included in the study. So that just kind of gives you the idea of when they were treating these babies. Finally, the follow-up on both of these studies came out. This one just came out, the Stop BPD one. There's no difference in neurodevelopmental impairment in the two groups. The DART group was a pretty small N. This one was bigger. And so, again, there's no evidence that there's going to be a difference in the two groups. And so we probably can assume that this kind of approach is going to improve short-term outcomes, lowering respiratory support. But there's not really any evidence in the individual papers for improved long-term respiratory outcomes in these individual studies. But there is for meta-analysis papers. And so maybe there's a research gap here of hydrocortisone versus DEX, including neurodevelopmental follow-up. I like to point out the research gaps in case somebody has a notion about doing something out there. Now, there are a couple of papers that have come out since we wrote our review that I think are very, very important and really good for everybody to know about and to understand. So I'm kind of highlighting them. I don't have any connection to them in any way, although they told me after I gave my talk last week, Heidi Harmon was actually a fellow in Rainbow. I didn't know that. She's in Iowa now. So this is part of a paper that was done with the NR and the Neonatal Research Network. And it's a really important paper. I will tell you that in the network, in this particular paper, in this cohort, of the kids who got steroids, about 73% got Dex and 27% got hydrocortisone. And it's roughly about 3/4, 1/4 in every single paper when you look at them. Now, what the authors did in this paper was they tried to look at the week of life that the kid got the first round of steroids. And so what you can see here is they looked at 4 bad outcomes: severe BPD, death or severe BPD, neurodevelopmental impairment, death or neurodevelopmental impairment. And for all 4 of those, the same week of life, the 4th week, day 22 to 28, was kind of the reference point for every single one of them. This one was a little bit lower if you gave it the week before, but they're trying to pick one week for the whole group to focus on. And if you look at the severe BPD, it looks like this is where the money is. You're going to try to give it between day 22 and day 28. Now, if you're not convinced by these forest plots, the people at what journal, this is Journal of Perinatology, I could not believe how much space they gave these folks to put these graphs in, because it's really important. This is very convincing to me, because in these are every individual baby time point. The nadir of every graph is that 4th week, if you look. And so it's pretty convincing, and I kind of blew one up. This is the BPD one. And the one that has the little pink asterisks there is that 4th week, day 22 to day 28, and that is the lowest point of the graph. So that means that if you go any time earlier, any time later, it's going to be ever so slightly more, have a probability of whatever the bad outcome is that the graph is showing. And so in the end, it does not actually reach, it's not significant. Like these 2 weeks are not different. See, they cross 1 compared to this. But by day 50, you are now not crossing 1 anymore. And it is now significantly more likely that you'll have severe BPD. And you can look through each graph and pick whatever outcome you think is the most interesting one. But the point is, you know, your best target is probably day 22 to day 28. I'm a kind of a math geeky person, so I found very convincing. And by day 50, for sure, now you're going to start to see significant differences in these 4 bad outcomes. So that's the Heidi Harmon paper. Just for fun, I looked at some babies. When I say I, of course, I mean somebody else pulled the data. Jamie Marish is one of the PharmDs, and she pulled this for me. And we looked at 19 babies just to get a feel for when are we giving DART to these kids. And our 50th percentile median was day 26 of age. Our 25th percentile was day 19. And our 75th percentile was day 30. So that's our interquartile range. And much to my relief, we only found 1 baby who got it after that magic day 50. And that was only 1 out of 19. So I kind of liked that. And then I said, well, is it really true that they're going to have less? You know, is there going to be any difference at 36 weeks in these babies? And we don't have a yes/no BPD as our outcome here. What I have is the breakdown of different respiratory support that they're on. The legend is way at the bottom. I hope you guys can see it way down here. But the graph on the bar on the right are babies who got, so this is 59 babies. The graph on the left is babies who got their first start course less than 28 days of age. And the babies on the right are the ones who got their first dose of DART after 28 days of age. And you can see in this group, there's more babies still on a vent at 36 weeks. And here there's more babies on nasal cannula and room air at 36 weeks. So anyway, just always good to look at your own data so you can see kind of what's happening. So this kind of made me think maybe this 28-day thing is really a good target, that 22 to 28 days. So these are these 3 pretty good randomized controlled trials. And you can see what's nice is that all the follow-up is now available. No difference, no difference. This one, the hydrocortisone, remember I told you in the lower gestational age group, 24 to 25 weeks, was actually a little bit better. So I think this idea that the steroids are hurting the brain in every study is so terrible is really not panning out in the more recently done studies, where often we're starting steroids a little bit later than in years gone by, and we're also giving lower doses than in years gone by. So I think we're kind of in a better place in terms of the risk to the brain. I do want to point out one thing in this online study. This is the Stop BPD study. So, you know, you look at the primary outcome, and you can see there that 70% of the hydrocortisone kids got the combined outcome of death or BPD. The placebo group, it was 73%. So that looks kind of good, 3% difference, 3% lower in the hydrocortisone group. But when you look over here, you see the p-value was not significant, and these all cross 1. And so then we say, okay, what about the individual components of this outcome? And this kind of brings up the idea of competing outcomes. So if you look at death here, death is 15% in the hydrocortisone group and 23 to 24% in the placebo group. That does reach statistical significance. And, you know, that's obviously an important outcome. And we like to see that the drug that we might be interested in is going to decrease mortality. So that's great. But then when we look at the other component of the primary outcome, which is BPD alone, we see that, oh my goodness, it's 55% versus 50%, 55% in the hydrocortisone group. What the heck? I don't want to have more BPD. Well, it turns out you have to survive to get to 36 weeks and have BPD. So if you have more death, you may have less BPD simply because you didn't survive. And this kind of should be something that we're always, this is why we use this combined outcome thing, because if you found a new drug that cured all BPD, but everybody died, they wouldn't have BPD, right? So you have to just be thoughtful about this. And this isn't always something that people see. They come down here, they look at BPD, say, oh my God, BPD is higher in the hydrocortisone group. Well, it's a little bit more nuanced than that. And so just good to kind of remind yourself of these things. So this paper is the second paper that I want you to know about and really think about and look at yourselves. But this kind of brings up the idea of competing outcomes. And this is a paper by Helena Whitehead. And it turns out she was actually a case medical student, and she worked with one of our neonatologists here, Monica Bola. I don't know her at all. And this is out of WashU, so it's their own patients. It's not from the NRN. And this is a fascinating paper, actually. And so it's a little confusing at first. So I'm going to kind of try to go slowly. I'm not good at going slowly, but I'm going to try. So these graphs on the left are reporting the risk of moderate to severe BPD in both graphs. And the graphs on the right are looking at risk of death of BPD on the y-axis. They are all, every baby in all of these graphs are all 24 weekers, and they're all looking at them at day of life 7. So that's not different among the four groups. What is different is that the top are males and the bottom are females. Turns out it's not going to make too much of a difference on it, honestly, but just so you know, they did look at that. They kind of looked at the groups separately. And then the x-axis in all of the graphs is the same. It is increasing FiO2 from left to right. And so if we just if we just pick one thing to look at, we'll look at risk of BPD in the males at day of life 7. We see that as your oxygen is higher on day 7, wouldn't you think that your risk of BPD would be higher, not lower? But it turns out it's lower. And it's the lower FiO2 babies that have the higher risk of BPD. And, you know, that's not intuitively obvious until you go over to the right-hand curves, which are the risk of death curves. Kids who are on higher oxygen are more likely to die. So they never make it to 36 weeks to have BPD. And the kids who are on the lower oxygen, they have less likelihood of dying, so then they could have more BPD. So it's kind of an interesting little conundrum there. And then there are a couple of other interesting things here. So this green line, that's the 60% line. This was the line that Lex Doyle and some other people recommended for giving steroids. Well, don't give steroids if your risk is really low, only 10% risk of BPD. Give steroids if you have a 60% risk of BPD. And so if you look at this carefully, they separated these babies out into white and black babies. And if you use this 60% cutoff, no black babies on average would ever get steroids because they're always below the 60% cutoff. You say, well, and a few white babies in the low FiO2 groups would maybe get steroids. So then I go, okay, why is that? So then we go back over to the death curve here, and we see that the red line is about 10% on average higher than the blue line. That's the black babies having about 10% more mortality for the same FiO2 than the blue line, than the white babies. So this was a very, very interesting paper that told us a lot of different things. But again, this idea of competing outcomes is really, really important to think about. So that's the second paper that I recommend everybody read if you really want to use steroids and have, know what you're doing. Read the Harmon paper, read the Whitehead paper. So then my next slide is, can this get any more complicated? And actually, yes, it can. Let me show you how it can get more complicated. So this is a paper from Eric Jensen. This literally just came out this year. This is not a randomized trial. This is the cohort of babies from the NRN born during this time period here, less than 27 weeks. And as I mentioned to you, they're pretty much always sticking with this 35-25% dex and hydrocortisone. Some centers maybe a little bit more on the dex side, some more on the hydrocortisone side, but that's pretty much what you see in most of their papers. And these are babies who got their courses started between day 8 and day 42, and they matched them with non-steroid babies. And so they had 482 pairs of babies. And they looked at the corticosteroid babies and the untreated babies. And you can imagine that there's going to be some difference between those two groups. This is not a randomized study. One group's getting steroids, one group's not getting steroids. So you're like, okay, and you're reading along. And then this graph appears. And you're like, okay, now I've got to really pay attention. I got a lot of circles here. This is every baby now they're giving me. So here, what's on the x-axis is the estimated probability of death or grade 2 or 3 BPD. So I'm just going to call this death or BPD. But it is the higher grades. This is the Jensen definition now of BPD at 36 weeks. So these are babies who have a higher risk on this end, right? And these, the babies down here, have the lower risk of death or BPD for both graphs. The y-axis on the top graph is risk difference of death or neurodevelopmental impairment at 2 years. On the bottom, it's risk difference of death or CP, cerebral palsy, at 2 years. So this is risk difference. This isn't the absolute risk of death or neurodevelopmental impairment. It's the risk difference in the group who got the steroids versus who didn't get the steroids. So what they found, which is, and again, you got to read these papers and read them very carefully to really understand. I have to go back and read this one actually, but they do give us a little hint here. See, this favors corticosteroids, favors no corticosteroids. So on the babies who have the higher risk of death or BPD, they're going to get a little extra benefit from the steroids in terms of brain outcome, both neurodevelopmental impairment and CP. Whereas the kids who are on the lower end of the risk of death or BPD, they're going to get a little more harm from the steroid for both neurodevelopmental impairment and CP. And the way they wrote this in the paper, I think, is maybe helpful to understand a little bit more, is that the risk difference for death or neurodevelopmental impairment associated with steroids, so it's not the absolute risk, it's the risk associated, the extra risk or benefit associated with steroids. This decreased by 2.7%. This line is going down by 2.7% for each 10% increase in the pretreatment risk of death or BPD. So as that risk of death or BPD increases by 10% each time, this is going to go down by 2.7%. That 2.7% number is replaced by 3.6% for death or CP. So maybe this line is a little steeper. So again, this is like your brain is like getting full now, and I totally understand that. It's really tricky. I blew this up a little bit just so we could see one a little bit closer up, and it doesn't, it's the top graph that I already showed you, so it's not new, but you can see that these guys are going to have a little bit of harm. These guys are going to have a little bit of benefit. Somewhere in the middle, it's probably a break even for the brain, whether they get steroids or not. And so kind of the summary here is that the results of this study suggested that corticosteroids were associated with a reduced risk of death or disability in infants at moderate to high pretreatment risk of death or BPD, but with possible harm in the lower risk babies. So something else to think about when so is it really a kid who I really think is going to get BPD? Or, I'm not really worried about that kid. So that's another thing now to kind of think about and fuss about. And then just to give us a little added information to think about, they broke it down in the dexamethasone treated kids and the hydrocortisone treated kids. And the hydrocortisone line is the orange line here. And it looks like that effect of a little bit of benefit here and a little bit of harm here maybe is a little bit more exaggerated in the hydrocortisone babies compared to the dex babies. So that's that paper. Now, this might look a little bit familiar to those, especially those of you a little bit older. You may have seen this paper from 2014. This is a paper from Lex Doyle, Henry Halliday, Rich Aaronkrantz, et cetera. And it's kind of a similar idea that as the rate of BPD in the control group went up, the risk difference for death or CP, they didn't look at NDI, they just looked at CP, is lower in the kids who are the higher rate of BPD kids, but possible harm in not giving steroids to the kids with the lower rate of BPD. So again, this is another paper, very similar, a little bit maybe simpler, but it's all making your brain hurt. But it's good to know if you're going to give a kid steroids, you need to know about these papers. And then I'll just throw in this last one that is not as complicated as the Jensen paper, but basically this paper is an analysis of the hydrocortisone versus placebo study that was done by the NRN. And they took that cohort. So now they have a randomized cohort as opposed to the Eric Jensen paper, which is just a whole group of babies. And this is a secondary analysis from this study. And they looked at the same kind of concept, and they found that the effect of hydrocortisone, because there's no dex in this study, right? It's a hydrocortisone study. The effect of hydrocortisone versus placebo was not appreciably modified by baseline risk for grades 2 to 3 BPD or death. And maybe when you have a randomized cohort as your study cohort, it's a little bit more believable, but I kind of believe both studies. There's a lot of N in both of these papers. So this one isn't quite as complicated, but I just gave you the summary. That's probably why it's not as complicated. All right, now into this later evolving BPD section. So this is after 28 days and up to 36 weeks post-menstrual age. There are no randomized control trials. There's just a couple of anecdotal papers that I want to share with you. One of them is my own, so of course I'm taking the liberty to show you this paper. This is a paper from Buffalo that we did. These babies were born quite a while ago. And at that time, everybody in the group had equipoise. Some people gave dex, some people gave hydrocortisone, some people gave methylprednisolone. And you can, so these babies is not a randomized trial. They're all of the babies in our unit. And you can see that the age at the days when steroids were started was significantly different in the, a little bit later in the dex babies and a little bit earlier in the hydrocortisone and the earliest in the methylpred group. And then you can also see that the we kind of turned all of the doses into hydrocortisone equivalent dosing. And there are some differences in the dosing that we were using, and Dex is kind of in the middle of the other two groups. And then if you look at the baseline respiratory severity score, that is, pretty close, although the hydrocortisone group was the lowest, probably because they were started at the youngest age, perhaps. So it's a little bit of a messy retrospective study, but what we did find, you'll be happy to know, is that steroids do decrease the respiratory severity score. If you're not used to what that means, it's the mean airway pressure times FiO2. And you can see that in both, this is the whole cohort of everybody together. It does drop the respiratory severity score both at day 3, it's significantly, and at day 7. And then we tried to parse it out based on the 3 drug types. And it looked like Dex maybe was a little bit better at dropping the RSS, and it was significantly lower than the other 2 groups at day 6 and day 7. So it agreed with my bias that Dex probably works a little bit faster as an anti-inflammatory. Then we tried to look at, these are kids who are, I think I have some animation here, the kids who are on high frequency by the striped bars, the kids on conventional, and you can see everybody's kind of shifting over to the right, and the white boxes are the extubated percent of extubated babies. And there's a significant move over on day 3 and on day 7, both of them. When we tried to look at the 3 different drugs, we just didn't really have enough N, I think, to look at this. There was a trend of some difference at baseline, and you can see there's more white bars everywhere, but Dex probably has the biggest white bar by day 7, and none of that was significant, but it still kind of made us believe that probably Dex is a little bit better. Now, the other anecdotal study that I want to mention is one that is comparing hydrocortisone with dexamethasone, except it's in 2 different NICUs. This is a study that was done in the Netherlands. They used similar courses, both 21-day tapering courses. The steroids were started at roughly 2 to 3 weeks, so kind of technically belongs in the other category of less than 28 days, but don't hold that against us. And in this study was nice because it included 5 to 7 year follow-up. We don't usually get that kind of follow-up in the US studies. And so what they showed, a couple of things that they showed, this is comparing the control hydrocortisone group and the hydrocortisone group. This is one hospital. This is the other hospital. You can see the hydrocortisone and the control babies are basically exactly the same in their weight gain. The control babies in the Dex group are gaining weight, but if you give them Dex, they don't gain weight. Everybody in this room knows they don't gain weight on Dex, right? So that's not particularly enlightening, but they did kind of give a nice graph there. And then they looked at these long-term follow-up issues. They looked at neurological outcomes, psychomotor development, and school performance. And if you want any more details than those titles, you'll just have to read the paper for yourself. The citation is down here. And basically what they found is that in every direct comparison in the same center, the steroid group always did a little bit worse than the control group. That was true for hydrocortisone, and it was also true for Dex, and that was true for all 3 outcomes. And then if you compare hydrocortisone versus Dex, you can see Dex is always a little bit worse than the hydrocortisone. However, even the authors point out that, there are a lot of center differences. And the Dex center gestational age overall was a lot lower, 23 weeks versus 25 weeks. That's a big difference, actually. They pointed out that they saw the short-term effects that I've listed there were only seen with dexamethasone, not hydrocortisone. This study looked at 21 to 22-day courses, which the authors are saying are kind of less in use now. Everyone is going towards shorter courses. And they were kind of wondering or speculating that by lowering the Dex dosage or decreasing the duration, maybe we'd still see the beneficial effects of Dex, but the adverse effects would become more minor. So this 21-day thing, I just want to kind of let you know how I came up with that. So when we saw earlier that some of the reviews early on said that less than 7 days was a riskier period than more than 7 days for the brain, the lowest babies in those cohorts were 24 weeks. Now we have babies as early as 22 weeks in some of our NICUs. So in terms of the brain, they're not really the same. And a 7-day-old 24-weeker brain is probably around the same as a 21-day-old 22-weeker. So I try not to give Dex less than 21 days if I can help it. That's just my own personal thing. All right, so I'm going to skip over the, so what people are using in this time period is, I call it the Buffalo Protocol. It's really the Alan Jobe protocol. He basically got up one year at PAS and they, gave all this big science talk and everything. And then somebody from the audience said, well, Dr. Jobe, what do you do in the unit? And he said, well, this is what I'm doing. And those of you who are younger don't know the old protocol started at 0.5 per kilo per day. So this was a big, like, so much less. And was it going to really work? And yeah, it still works. And so I think any data in this kind of time period is probably useful from a research gap standpoint. We just have so little information. And yeah, we probably could also use a randomized control trial at these later time points, but maybe with that Heidi Harmon paper, we don't really need that anymore. All right, I want to talk about the established BPD babies. And I think, Clara, that's actually the group that you asked me to talk about. So there are only 2 papers that are worthy of mentioning, I think. One of them is, this looks like Vineet Bhandari, but it's actually his wife, Anita Bhandari, and she is a peds pulmonologist. And this is in red because there's a typo in the slide set that I gave you. It says 21, and that's incorrect. But I did check, and it is correct in our paper. So I could say thank you to Elizabeth Schultz for that, because she was the one that made sure everything was all correct, one of the authors. So this is the course that they used in this paper. But these babies were not on ventilators. They were just oxygen dependent. And the purpose of the steroids was to see if they could go home on no oxygen. And in fact, that did seem to work. The Linafelter paper is a little bit different dosing, but kind of the same idea, but a longer course. And then in the actual, the course that they report is only 28 days, but in the actual paper, they only included babies who got at least 30 days. So their own paper is a skewed population compared to what they are recommending as their dose. They were on vents as opposed to the Bhandari paper where they weren't even on a ventilator. I don't like to give, steroids for kids who are just on low flow oxygen to get them off oxygen. First of all, they may be better off to go home on oxygen. So, but if they're on higher support, I think that's reasonable. And then I kind of have a little bit of a rule. I like to use the Bhandari dosing because it's probably safer because it's shorter. And then I try to only go back once because, you're weaning, then they slip and it was, let's go back to the previous dose. And I let that go kind of once. But after that, I really fight hard to keep going on the wean because otherwise it could be on it forever. So this is from that review article that shows that as you go along in terms of these different paradigms and post-menstrual age increases, the starting doses and the cumulative doses keep going up and up and up. And this is especially true if they need more than one regimen, that's this example, or if they stall in their weaning for any reason. And I've noticed that since we kind of started talking about this, that people are starting to look at cumulative dosing now a little bit more. All right, so I mentioned the Harmon and Whitehead papers and the Jensen paper. I'm going to present one more paper that is important for you to know about. It's actually not a paper yet, it's an abstract, and the manuscript is about to be submitted. And this was presented at PAS at a session that I just happened to be moderating. The senior author is Talcott Raghavir, and they had beautiful slides. The presenting author is Risha. I can't remember if it's Lakotia or Lakosha, and I apologize, Risha, if you're listening or whatever, but it was beautifully presented. The slides were phenomenal, and they don't want me to use the slides because they're still submitting their manuscript. So you'll have to just see the actual words that are from the abstract. So this was a systematic review, including long-term follow-up and meta-regression. And basically, they looked at controlled trials of dex or hydrocortisone to evaluate the effect of systemic steroids on BPD and mortality. And they used different meta-regression models. And the outcomes of interest were neurodevelopmental impairment that includes cerebral palsy, mental developmental index, and PDI, psychomotor developmental index. And what they showed is they had 44 studies that they could look at, more with dex than with hydrocortisone. This was over 6,000 infants, 3,000 in each group, roughly. And what they found is that the risk of BPD was significantly reduced with dex, with a relative risk of 0.66, compared to hydrocortisone that had a relative risk of 0.98. And this p-value of less than 0.01 is comparison between dex and hydrocortisone. The dex seemed to work better to decrease the risk of BPD. Then they used these meta-regression models with permutations, and this confirmed the reduced risk of BPD with dex, relative risk now 0.75, and p-value that was significant. And they looked at medium, low, and high cumulative dose, and the medium cumulative dose here was 2 to 3 milligrams per kilogram. And they did not do regression modeling with hydrocortisone because they had fewer studies and most were at the lower dose. They didn't really feel that was worth looking at. They looked at long-term outcomes, and this is the thing that just sort of wowed everybody in the audience. It was a big audience. It was like there was no significant increased risk for either drug. For cerebral palsy, Dex was 0.98, hydrocortisone 1.15 relative risks, and no significant differences were observed either for either drug for MDI or PDI as well. And so hopefully this paper will be coming out soon. And they concluded that Dex at less than 3 milligrams per kilogram, initiated at 7 to 14 days, tapered slowly, appears to prevent BPD without increasing mortality. Hydrocortisone did not decrease the risk of BPD, but it was used in lower equivalent doses, so maybe that's not a fair comparison. They noted an increased risk for hypertension with Dex, but no effects on other things such as hyperglycemia, perforation, etc. And evidence showed that neither Dex nor hydrocortisone increased the risk of NDI at 12 to 36 months of age. So that should be coming out any minute. Now, just like, I'm giving these talks and people say, well, Dr. Ryan, what do you think? So I'm kind of less nervous about steroids, and Dr. Martin made me put this in as we use them today, and the brain. I like Dex better than hydrocortisone, except if less than 21 days of age. I'm kind of old-fashioned. I'll give them hydrocortisone, and I hardly ever do it less than 21 days anyway. I think Dex has better efficacy, and I think we're finding out there's no difference in the brain. I try to keep the dose and cumulative dose as low as I can. This is something that I feel very strongly about. Stop if nothing's happening after 72 hours. Well, what does that mean? What should be happening? Well, you're going to look for your drop in PCO2 or your drop in FiO2, and you're usually going to see one or both of those things. If you don't see them after something happening after 72 hours, for heaven's sakes, just stop and wait another couple of weeks and try it again. And I only like to use it in babies who I think will come off the vent. This is just my personal opinion. Lots of people give it to kids who they just want to decrease their settings, and I'm not saying that's wrong. So I've been targeting this day 22 to 28 thing from the Harmon paper now. If I don't think I can get them off at that time, I will try to put them on the jet for lung protection. This is just my own personal opinion, no data for this, okay? But I still try to start by day 50 based on the Harmon paper. So even if I don't think I can get them off the vent at that time, I'll still give it. So I'm going to talk to you about adrenal insufficiency. It's kind of overrated. And I want to talk about this prednisolone thing. And I'm sorry, I'm kind of running out of time here. I'll go through this quickly, Clara, so don't worry. So when are babies at risk? You can look at, you all have access to the slides, so I'm not going to read through this. There are two protocols that I was familiar with. One is the Buffalo protocol, where we didn't use any levels, but we really paid attention to how long we were going to have the baby in our own hands to be able to watch the baby. And when I got to Rainbow, we used one with cortisol level, and I thought this was very interesting. And so we wanted to look at this. So that's Lucy Mastrandrea, the now chief of endocrine at Buffalo Peds Endo. And this is actually in that same review article that we told you about at the beginning, the TON article. I think this graph is a little bit easier to read. So it goes by the length of steroids, how long you're going to watch them in the hospital, do you need an endocrine consult, when should you get the consult? It's like, come on, you just have to read the table and do what it says. And this has worked since 2008 very well. And when I got to MUSC in 2011, they asked me about, what do you do, and so it's been working there, and they're both still using it. I remind you about the potency here of these drugs compared to hydrocortisone. Pretty important thing to understand and remember. And this is the protocol at Rainbow, where you wean the kid down, wean him down till you get to equivalent of hydrocortisone dose of 7 to 8 milligrams per meter squared, or quote unquote physiologic dosing. And then we would hold a dose one evening, and then the next day, after 2 weeks on this, we would get a cortisol level. If it was less than 3, they would go back on the steroids. If it was 3 to 12, they would get an ACTH stim test, and we'd be watching them. And if it was more than 12, we didn't have to do anything. And this was underway for quite a few years. I don't really think you need cortisol levels. As I mentioned, we've been using this Buffalo protocol, for lack of a better word. I called Anne-Marie Reynolds. She's the chief there. They're still using it. I called back to MUSC just a couple of weeks ago to find out from the endo people there. They're still using it. If your endo colleagues are nervous, they don't know what to do, they can contact Dr. Mastrandrea. This is her email. She doesn't know I'm giving it to everybody, but I think she'd be happy to talk to anyone. And so I do want to show you that we did follow the looked at the kids who were on that protocol where we measured the cortisol levels. And I don't want to take away all of Kristen's thunder. Kristen Rosano is the fellow who did this project, and she's going to be presenting her poster on Saturday AAP, so please go to that. And it turns out we only found 8.5% of the babies who got at least 10 consecutive days of steroids had any kind of clinical concern for AI. Only 5.6% of any baby who met the criteria for an ACTH stim test failed it. And it turns out cortisol levels were not associated with either clinical AI or the stim test. And of the kids who got 10 consecutive days, you all think, oh, I'm stopping steroids, I don't give them too much steroids. Our median was 70 days of steroids, just to kind of let you know. All right, what about the established BPD babies? I told you about Bandari and Lena-Felter papers, but when are steroids indicated? And I feel bad to have to rush through this at the end here, but this is a protocol that's being developed by our BPD team. Monica Bola is a neonatologist, Jeff Lobus is a peds pump, Jamie Marish is pharmacist, and Megan Cooper-Sasse is another neonatologist. And what they've done is use the Jensen criteria to say, well, because I gave you the Lena-Felter and Bandari dosing in the paper and everything, but like, what are you supposed to do with our BPD babies? So if they're grade 3 and you can't wean their RSS, respiratory severity score, by more than 1 for 7 days, they're eligible to get prednisolone. If they're grade 2 and you're unable to wean by more than a half a liter in the last week, they can get prednisolone or methylprednisolone if it's IV. And if they're less than 5 liters, but they're having airway reactivity, then they can get methylprednisolone. So they get, here's the algorithm, and then did the patient respond? And I think this is really important. I like that they put it in red. So they actually defined this in great detail. So a response is that by 7 days later, you've met one of these criteria. You either shifted your support or something went down by 10 or 20% or whatever. It's got all written down for you. So it's fantastic. I put my email here. So if somebody wants this protocol, I'll be happy to share it with you. I did not make it. It's these folks up here who deserve all the credit. And they were just starting to use it. So we'll have some data at some point in the future. So this is my summary slide. I don't think there's anything too new on here, except I want to tell you enteral nutrition feeds the brain. Don't ask me why I stuck that in there. And I think having a protocol for your unit for these things is good. Less mistakes are made. And then if you ever do want to put any data together, you'll kind of know what the paradigm was. And there's still work to be done. So thank you. And I'm sorry I went over, Clara.
No problem. We love it. We will pivot. I had a really hard time keeping up with you for Neo Twitter, so or tweets to come. We were getting a lot of thank yous, claps, hearts. And we've got some questions here. It says, in the study from Buffalo, were all the neonates intubated before starting steroids?
Yes, those were all ventilated babies. We did not. I'm not a big fan of doing it in the kids who were not, but remember, those were old days. Everybody was still intubated. We didn't have high flow. We weren't as aggressive. We didn't have, like in Rainbow, I've got BiPAP. We didn't even have NIPPV in those days. So you either ventilated or you came off. And I don't know if the data would look differently now with all the other modalities. And so that's why I think the BPD team left it that the kids who were on high level CPAP, high flow cannula, not just ventilated babies, they kind of included those kids because in the old days, we didn't really have those modalities, honestly. But yes, the answer to your question is yes, they were all ventilated. Like you saw that one graph, everybody was either on high frequency or on the vent. That's in the paper. 100% of them at the time steroids were started.
We've got another question on thoughts on Premalock.
Yeah. I kind of gave you my thoughts. I haven't been advocating for it. I'm thinking that we are probably about average on our BPD. And I just think of all the kids who would get exposed who didn't need it. But I don't think it's wrong. I mean, it's very clear that it's beneficial. And actually in the smaller babies, the 24 to 25 weeks, their brain outcome was better. Now, these is just one study, so all of these things, like, should that study be repeated? Maybe it should be. I don't think it's wrong if you want to do it. I think it's perfectly reasonable. I'd probably have a conversation with your colleagues. What I don't like to see is you do it and nobody else in the group does it. That's very confusing to your nurses, to your parents, because they're all talking out in the family room. What do you mean? Your baby got steroids, my baby didn't get steroids. So it's good to have some consensus. Maybe that's a thing where you take that paper and you dissect it in a journal club and you really, look at it carefully and see if it's the right thing for your group. But I think it's a great study, actually.
I like that idea, the journal club. We've got another question on thoughts about timing for concurrent antibiotics for suspected sepsis and starting antibiotics. Or I'm sorry, steroids.
I did this talk for our fellows a couple of weeks ago, and one of them asked the same thing. And I got to tell you guys something, because maybe not everybody knows this. In the old days, when we first started doing this, everybody got a blood culture before their steroid, and you waited 24 hours till you started the steroids to make sure that they weren't infected. I think this is a difficult thing. The only thing that I know for sure that is really worsened by steroids, the only infection, is adenovirus. There's a lot of data in older children and adults that steroids might not be bad, actually, even for infection, but everybody worries about this risk. I think pneumonia in particular is, something that you think about because you're giving it because their lungs aren't that good, right? But I think it's kind of overblown, and I don't do the blood culture anymore. I've stopped doing it years ago. I stopped doing a lot earlier than a lot of other people because it never came out positive. I mean, the kid's sick, maybe that's not the day to start DART anyway, right? Because you're not going to see the effect that you want to see and know whether it's working or not. But if the kid's not sick, I think getting cultures on him is just not, I don't think it's necessary. I wouldn't be aggressive with steroids if I thought the baby had an infection at the time. But, an infection like a boo-boo on his hand, maybe not. But if he was acting sick, yeah, I probably wouldn't give it to him. And I don't think we have enough babies in any of these studies to know whether an acutely sick septic kid is ever even enrolled, so I can't answer that based on data. I just don't perseverate on it myself. I kind of get the gestalt. Somebody's worried about this baby. They just did a sepsis workup last night. Okay, maybe I'm not going to start the DART today. Maybe I'll wait a day or two.
That sounds very reasonable, especially with the boo-boo on the hand. We've got a question here about, do you use the BPD calculator to assess risks versus benefits of these steroids, maybe per the Rita protocol?
I don't. My thing is, are you more than 7 days old, and does your x-ray look like BPD? And by that, I don't mean like the worst BPD we ever saw, but if it looks like the worst BPD ever saw, that's going to be encouraging me to maybe be more aggressive. I just never got used to using the calculator. And now, based on that Whitehead study, I'm kind of nervous about the whole thing about the risk assessment because, it's maybe not the way to think about it. So just look at that paper carefully before you really hang your hat on that. The BPD calculator works. It's an accurate assessment. But I think if you're still on a ventilator, you probably at least deserve somebody to think about it. If you're 2 weeks old, your x-ray's starting to get that change, which happens as early as, 10 days to 21 days. Some of them look horrible. Like, okay, now I'm thinking about it. And I target that day 22 to 28 time period, and I'll try to do it by then.
And we've got a question here, and I think maybe you alluded to this already about a second course when you fail the first failure to extubate on the first course of DART.
Well, hopefully you stopped the DART if it wasn't working after 72 hours. Now, sometimes it looks like it's working, but the kid still fails extubation. You give him the whole course, you're waiting for that magic day. And I do try to do it as early in the course as I think they might come off. I don't have any magic numbers to give you about that because, the longer you wait, the less days on steroids they have left. So if I can get it done day 3, day 4, day 5, somewhere in there, I'll try to do it. The best thing is to have an aggressive fellow on at night because they'll take it out by the morning, But I don't have a magical formula for that. But if they fail, I will give it again. But I usually try to give it a couple of weeks for their lungs to hopefully heal a little bit and maybe have a better chance for them having success. And I used to have a magic time like of a month or something. I can't remember what I did, where I would say, I'm not going to, and I know people won't do it within 2 weeks for sure. And maybe I try to bump that a little bit longer. And if they don't come off, I'll have a low threshold to put them on the jet to kind of give them some lung protection. Also, no randomness, no trials about that. One question I saw come across was about NIPPV. There's no studies for that. I'm not saying it's wrong to do it. I don't do it. I figure if they can make it off the ventilator to NIPPV, they're probably going to be okay in the long run. Maybe they'll still technically have BPD because at 36 weeks they'll be on oxygen, but they're going to be okay. They're going to be a kid who's going to do okay from a lung standpoint. That's just what I think.
Yeah. And we've got a question way back from above. What do you think of the paper below? using doses we used many years ago. If I'm not saying this correctly, Sandra, maybe you can unmute and pipe up. Oh, I heard myself.
It's a Syracuse paper with the 42-day course, and I don't know if it's the exact doses we used in the past. I can't remember, but I remember in the past we did 42 days and repeated if they didn't do well. It was very high doses, but there's a paper that came out of Syracuse a couple years ago that, actually looked pretty good after, my always thinking that some of the neurodevelopmental issues came from those longer, higher dose courses, and that maybe we're not seeing them with shorter courses, but they had sort of what appeared to be good outcomes. And I haven't read the paper in a while, so I'm not 100%.
So I was in Syracuse as a resident, so I was kind of there when all of this discussion was going on, and Jim Cummings was the fellow, and I believe he's the first author on the actual study paper, maybe not the follow-up paper, but the study paper. And, that amount of steroid was really high. And you see the 0.2 or 0.15 that we're giving in DART, 0.2, the so-called Buffalo, the Jobe protocol. I mean, I remember those guys, there was a big session on steroids, and these 0.5, that's what everybody gave. That was the Avery protocol, not Mary Ellen Avery, the Gordon Avery protocol. That was a study that was not a randomized trial, but and I believe it was only done for 72 hours or something. No, it was 42 days. It was like 72 hours was the 0.5, and then it would go down every 3 days. And we did that on many babies. But that's when a lot of the data that came out about bad brain effects came out. And so this is a single study, this Syracuse study, not a ton of N in the follow-up part. They had a decent N for the trial, but the follow-up, this is from my memory, so kind of caught me off guard. I wouldn't put everything on that paper, honestly. I wouldn't walk around saying, oh, look how it's perfectly safe. I don't feel comfortable with that. We have so many other papers in addition to the Cummings study or Steve Gross study that we can look at, all these meta-analyses now that are pretty encouraging about the brain outcome. You don't need to hang it on one paper that's at one center, one small center. So yeah, but yet I would not use those doses. They're not necessary. You see the same effect. Now, that would be a great study if somebody could do that. But we're never going to use those 0.5 doses ever again. They're just way too high and probably not, those probably are really not good for you.
A follow-up from Dr. Short here about the impact of postnatal steroids on ROP. Any thoughts or comments on that?
Nothing off the top of my head.
There's a paper on it that somebody published. I think I put the link to it there. And I haven't read it in a long time, but maybe it was just a couple.
Who's the first author?
It looks like Shekwata. Is that right? It sounds like it was.
I don't know what I'm doing. I can't. Let me see if I can see the chat to copy this.
Senior author is Sears, Jonathan Sears, but it looks like it just came out in June of this year.
Okay, I might have missed it, guys, in one paper, I will look and see if I can find it. I know Jonathan Sears, actually, he's an ROP guy, and we've talked a lot about the effects of oxygen and stuff. So I would like to see that paper. Thank you for alerting me to that. I haven't seen it. In the large meta-analyses, I don't think ROP comes out very often in any way. That's just from my gestalt. I haven't noticed it like I've noticed some other things. So I don't know that I'd focus on that too much, but I will look at this paper and maybe I'll have something different to say the next time I give this talk. Thank you very much for bringing that up.
And we've got another question here about shorter courses of steroids, particularly for airway edema. Is there any thought that these are beneficial to lower the risk of BPD?
I don't know that they have anything to do with BPD per se, because they're usually very short. Like I know we've used like 0.25 per kilo of dex, Q8 times 3, try to extubate them in between the first and second dose type of thing. Everybody's got their little different way of doing it. I don't know that they have anything to do with BPD, except maybe you're able to get the kid off the vent because of the airway edema. Like, the kid comes off, somebody thinks he has a little bit of stridor, so they want to give him some steroids, and then that kind of helps him from a lung standpoint, and he's less likely to have to go back on the vent. But there's no studies that I know of. I could make up a story like that, but there's no studies that I know of. Oh, when do you start transitioning to BPD settings? What a great question. I'm working on that right now. And I think the BPD Collaborative is actually working on it as well. And they're likely to get to it before I do. But I think it's a great question. And Monica Bola, the person I told you who's working on our BPD team, she's the person that could answer this. Really, the answer at Rainbow is when Monica tells us, but that is not really the right answer, right? So.
Okay. Yeah, we're gonna need her. We're gonna need a bat phone to Monica. How
Yeah.
about this next one here from Julie? Do you start steroids in a neonate with large
Wow.
PDA?
Julie,
If
you're
you
killing
suspect
me.
it's causing some degree of pulmonary edema, or would you treat the PDA first? This is kind of a hot water topic.
Yeah, I'm going to Thailand. Richard Martin runs a conference there every year, and for some reason he wants me to talk about the PDA. And I'm just going to have one slide that's like a big question mark, because honestly, we really don't know what to do with the PDA. When should we treat it? When shouldn't we treat it? And everybody's in their different camps. And if I really think that there's a lot of pulmonary edema or total body edema, I guess I don't give steroids unless I think I can get the kid off the vent. And if the PDA that you're talking about is giving the kid a lot of trouble, I probably wouldn't give him, I wouldn't waste my dart on that. I'd wait until I got things under control better, whether it's from fixing the PDA or giving the kid more time. The NRN is doing a randomized controlled trial for PDA treatment, whether to do expectant management or have them enrolled. And I had this baby with horrific renal problems that I clearly attributed to the PDA. And when I went to, they said, oh, can we approach this mom? And I'm like, yeah, thinking to myself, this kid's never going to get in the trial. The creatinine's like 2.1. Well, it turns out the kidney doesn't matter for enrollment. It's only about the clinical status of the respiratory status and the clinical status on the echo of the heart. So the kid gets enrolled and gets randomized to expectant management. And I could feel myself sinking, going, oh, maybe I shouldn't have let this kid get enrolled. And then the next day, the creatinine is dropping, the ductus is closing on its own. This is why we need the study, because if I had given that kid a drug, I would have thought I was the smartest person in the unit, right? But it turned out he was just going to close anyway.
So we're at time now, but we've got 2 more questions. Oh, sorry.
Okay.
I'll just try to squeeze them in. If hydrocortisone is used prior to 21 days, do you still use or always use the 22-day course or the 10-day NRN course?
I use the 10-day DART course, which is the Lex Doyle original DART paper. And if I use it prior to 21, if hydrocortisone is, excuse me, I will, let's see, the NRN, oh, you mean the one in the randomized trial? See, I never give it before 21 days. That's why I'm sort of struggling. I mean, I hardly ever even give hydrocortisone prior to 21 days. I don't know. I'd probably make up something that was equivalent to the DART course, because I'd probably use the Stop BPD course, actually, which is that's 10 days, right? I can't remember. I think 22 days is probably too long for all of these courses.
Yeah, that seems to be the consensus, I think. And last question here is, given all of...
I love this question. So when that lady, Risha Lakotia and Talcott Raghavir, when they were presenting that data at the very end of it, I was the moderator, right? So I said, you guys, who in this room, there were like, I don't know, 1,500 people or something in the room. I said, who in this room is on the committee for the committee on the status of the fetus and newborn? And poor Ambul was the only person in the room from the committee. And he like kind of sheepishly raises his hand. I go, Ambul, we got to get this statement off the books here. People freak out. Did you inform the parent? Do you know how many other things we are doing that are far less studied and far riskier? And we don't inform the family of any of those things. So I have no excitement about informing the family. I try to talk with my parents on a daily basis on rounds. We're thinking about the steroids. It's usually not something you're doing in an emergency situation anyway, but I don't freak out if we haven't informed them that day. I don't, I think it's overblown. I think the risk for adverse neurodevelopmental effects is probably a lot lower than we used to think, because we have more data that says it's lower. We used to have the data wasn't bad before. It was just the studies were very different. They were heavily influenced by a couple of studies that started the steroids on day 0, kept them going for 28 days and at higher doses. So, it's not that the baby's brains aren't changing. We're just doing our steroids a little bit differently, and we're getting a little bit better results. So I don't think, it wasn't wrong before to inform the family, but I don't feel this same like, oh my God kind of thing now anymore.
That compulsion
I agree with you.
Dissipated. And I've got a meeting with Ambul on Thursday, so I'll prod him a little bit on that.
Tell him it's time to get on it,
Yeah.
When's that? Unfortunately, the only one there. I felt bad for him when I asked, like, who's here from the committee on that? And he's like,
Poor Ambul. But he will pull through for us, I'm sure of it. So again, we are We are at time. Thank you we're a little bit on time. Thank you so much for joining. We had over 150 people join. That's one of our highest. Please join us. Yeah, please join us next week or next month, sorry, at the third Tuesday. We'll be talking and shifting to neuro, mild HIE and therapeutic hyperthermia with Dr. Sonia Bonifacio. Now, I just want to give one last shout out to Rita because you are over 230 publications is what I saw just on the subject alone.
No, that is not true. And the 1948 is definitely not true. And I clarified on social media that paper came out in 2000. I looked at the 230 quickly. I don't go on Google Scholar, so I wasn't really sure. And they all look like papers. At first, I thought they must be counting some abstracts. I don't think the number's quite that high. Although I liked seeing my H index that high, and that I think is accurate. So maybe they really are all my papers, and they looked like all my papers, but I could have sworn that I had a lower number, and nothing in 1948. I am not quite that old.
I thought that was weird, and however, I thought maybe it's when she was a resident or something. But anyhow,
well,
it's out there. That's what Google says.
Yeah, I'm gonna have to fix that. I might have to call you, Clara, to help me fix it.
Okay. Yeah.
Go to my Google page or whatever.
We can do that, the branding part, but it's very impressive. And then also we've got some requests for the slides. Rita has been very generous with her expertise and with sharing, so we do have the slides to bring out. Please email me or text me any way you can find me, and I will send them out to you. Thank you so much. And see you all next month.
Thanks, Clara.
Thank you.